Good evening, everyone, and welcome to this evening's webinar on advanced approaches to central venous occlusion recanalization. My name is Jody McKeel, and it's my pleasure to be representing the Baylis Medical Technologies education team. As a quick housekeeping note before we get things started this evening, we do encourage everyone who's tuned in this evening to ask any questions that you may have to our panel of expert faculty, and you can do this using the Ask a Question feature that's located beneath the live stream. As a quick note, you may need to scroll down beneath the live stream in order to find and utilize the Have a Question feature. It's now my pleasure to introduce our program director and moderator for this evening, Dr. Dheeraj Rajan. Dr. Rajan is an interventional radiologist and professor at the Department of Medical Imaging at the University of Toronto in Toronto, Ontario. And with that, I'll hand things off to you, Dr. Rajan.
Okay, Jody, thank you. But thank you for the audience joining tonight. We actually have a large number of people participating. It's always hard to find the time to do these things. So we value everyone's effort to join us tonight. It's a pleasure to have you all here. We will try to live up to the experience to make it a very positive one for everyone tonight. Joining me tonight is, next slide, please, Dr. Mark Lessne, terrific guy. He's an assistant professor down in Charlotte, Virginia. And then we have Marcelo Guimaraes, a good friend of mine. You'll see from his webcam, he's trying to escape to the Canadian border in his car right now. I don't know why, but he's still doing this webinar while he's escaping the United States. We have a tremendous program tonight. If I could have the next slide. And we're trying to cover everything here, but Mark is going to cover standard approaches, but when standard approaches have failed, what advanced approaches are possible. And then Marcelo, who's been at this for quite some time, is also going to talk advanced crossing techniques for complete CVOs. I'm going to round it out by saying I'm going to do a bit of a literature review here, but we're also going to look at managing complications and how, after we've worked through this, what the three of us do to keep things open. There's no point in doing this and then having it closing off a week later. You really want this to last. These are complicated patients. So once you have that technical success, you really do want to have great patency. So with that, the structure of the program is there are 3 pre-recorded talks. We will take a question or 2 or 3 between each talk, but we will round it out with a question period at the end of the presentations as well. So this is for you. Please ask the questions after each talk. We want everyone to get as much out of this as possible. With that, I think we'll go on to Mark's talk.
So thank you for joining me. I am Mark Lessne, and I will be presenting on crossing venous occlusions. When standard approaches have failed, what next? So here are my disclosures. Okay, so over the next 12 minutes or so, what I want to do is review central thoracic venous anatomy, define what TCVO is, and then I want to describe and demonstrate sort of crossing techniques for central venous occlusions that hopefully you're all familiar with, but more importantly, introduce second-line treatment options for TCVO when the first line fails. So what are we talking about when we talk about the central thoracic veins? Well, generally we mean the subclavian, brachiocephalic, and SVC veins. That's usually bordered by the first rib and the thoracic inlet. And that's really important because when we start talking about lesions that extend to the axillary or certainly brachial and jugular veins, our treatment paradigms and our crossing techniques and sort of what we can do changes. So that's something to be cognizant of. We use the term TCVO, and what that is thoracic central vein obstruction. Now, keep in mind, an obstruction could be everything from a stenosis, a 52% stenosis, to a total occlusion, chronic total occlusion. And that's what we're going to spend most of our time with today, which are the most complex lesions to treat. There's also some other entities, such as thoracic outlet syndrome, which certainly could be venous, arterial, or neurogenic, and that's not what we're focusing on today. And then we'll also mention a little bit about what to do with device-related obstructions, either implantable cardiac devices or oncologic devices. So when we talk about TCVO anatomy, there's certain patterns of obstruction or occlusion. And I'm not going to go through it, but there's different types, everything from a unilateral jugular or subclavian obstruction, which tends to be less symptomatic than a total SVC or bilateral brachiocephalic vein obstruction. Not only that, but our crossing techniques and our therapeutic paradigms are going to change based on the type. When we evaluate patients, we talk about dimensions of TCVO. And what that means is, first of all, what is their pattern of obstruction? What type of flow is it? What's the degree of obstruction? Is it a stenosis or is it a chronic total occlusion? How long? What are their symptoms? And we'll talk a little bit about the symptomatology in these patients, that not everyone has symptoms. And that's really important because we don't treat asymptomatic patients unless we have a different goal in mind. For example, getting to the right atrium because they need a catheter or something like that. Duration of symptoms, which are somewhat arbitrarily defined as acute, subacute, chronic by these days. Signs on physical exam, and then performance status. How debilitated are they? When we evaluate these patients, it's important to look at symptoms. Commonly, these patients present with edema, postural syncope. Certainly, dysphagia and stridor can be an ominous symptom of really severe disease. Dyspnea, chest pain, visual changes, and in some cases, confusion optimization. I will remind you that not an insignificant percentage of central venous lesions are actually asymptomatic. And so, in fact, in one study, patients with fistulas, only about a third had symptoms. In patients with leads, cardiac leads, there's tons of stenoses out there, but actually less than 5% are symptomatic. And that's really important because we don't treat asymptomatic patients unless we have a specific goal in mind, getting a patient a catheter or a lead. So what causes central venous stenosis and occlusions? Well, certainly we see them all the time in dialysis patients and pacemaker leads. Catheters and pacemakers are strongly associated with occlusion and obstruction. The larger the dialysis catheter, the larger the diameter of leads may worsen the obstruction. Why? So this leads to trauma to venous endothelium, which can cause acute thrombosis, or, as we'll talk about, proliferation of the smooth muscle cell. You can get inflammatory damage at the time of insert, and certainly turbulence, tangential wall stress. All this leads to SMC, smooth muscle cell hyperplasia, which is shown here. Repetitive needle puncture in dialysis patients can lead to endothelial disruption and fibrotic wall changes. Not only that, but patients on chronic dialysis can have a chronic inflammatory state that causes a foreign body reaction. So we're fighting a lot of challenges in these patients. So that's all way of background for why we're here. What are we treating? Obviously, you all are tuning in, and so this is a part of your practice, and I applaud you taking on these very challenging patients. So let's talk about central venous recanalization techniques. So don't forget, all of vascular work, endovascular or vascular, is inflow, outflow, conduit. Okay, you got to have a good channel in, good channel out. You got to have something connecting it. Well, that's not always true for central venous occlusions, because sometimes, like we talked about, we just want access for a cardiac lead, a defibrillator, a port catheter. And sometimes we just need to get to the right atrium. And that's really important because that's going to differ on your approaches. So when we talk about crossing these obstructions, or in this case, occlusions, because we're no longer going to talk about stenoses, we're talking about the most challenging obstructions that are actually fully occluded. Technique is key. And that really starts with support. Support means at least a triaxial system, either a sheath, a long sheath. I will often put a guide catheter through that with a valve to make it a sidearm valve, a hemostatic valve, and then put your diagnostic catheter or crossing catheter through that. And that provides a very robust support. What I like to teach people, which was taught to me, was take the fight to the site. Okay, don't work a mile away. Go right to that lesion. We use a lot of hydrophilic wires. 035 is our mainstay. Certainly 018 may have a role, and CTO wires with gram tips we'll talk about. So this is just sort of a common way to cross an occlusion. This is occluded, but actually fairly easy. You dig your catheter in, you've got your sheath all the way down, and then your wire just crosses. Sometimes it's a little bit more challenging, which hopefully you're all familiar with, where you're trying to find the channel, and you have to rotate your catheter until you find the right channel. It may look occluded, but there actually usually or often is a small channel that you can get your wire through and then follow it with your catheter. Now, suppose you've done all that and you are not able to cross antegrade. So what now? Well, here's an example of a patient with a long segment SVC occlusion, absolutely nothing getting through. I was not able to get through with an 035 catheter, so I converted to an 018, and it passed right through, and I was like, perfect. Well, except when you do your run, which you always do before you intervene, that's not the right atrium. In fact, that's a pericardiogram. Now, if you just cross with an 018 system, that's usually very safe. You can just pull back. It's a low pressure. Obviously, you don't want to dilate up. But the problem is you still haven't crossed. So what now? Well, keep in mind there has to be another way, right? And we know there is. And it all starts with access. And that's the most common secondary approach, that if you can't cross in one direction, you cross in the other. So commonly we'll stick the jugular, the femoral, the brachial, or the pop, certainly for lower extremity interventions. But there's other accesses that are at our disposal. A direct brachiocephalic, tibial, hepatic, or direct IVC stick that allow us to come from a different direction if some of the other options aren't available. Sort of quitting at this point should not really be an option. And so that's exactly what I did, came from below, and this was actually quite easy to cross from below, and was able to do that even when you can't cross from above. And then you stent with whatever you need to do, or just put a catheter in, or whatever it is you're there to do. So let's move on to the next stage, all right? So for you all tuning in, it's clearly because you have an interest in the most complex occlusions. So you've tried everything, you've gone antegrade, retrograde, 035, 018, nothing's working. Now what? Now for these patients, we talk a lot about sharp recanalization, and that can mean different things for different people. So sharp recanalization could be everything from the back end of a guide wire to a weighted wire with which we use for peripheral artery disease, but it's got gram tip load, so a 30-gram tip load, a 20-gram tip load that actually puts some weight behind it, or the back end of one of these wires, which is really an 014 or 018 spear, a TIPS needle, some other needle, transeptal, chiba, whatever it is, and then something else, which we'll discuss, and obviously that's why we're here. Anytime I convert to sharp recanalization, I will tell you a CT is mandatory in my practice. There's a lot of dangers that lurk around here in the chest. Here's a patient with an SVC occlusion, and I will remind you, that is where I need to go, that red arrow. Well, look what's all around it. So your margin for error and your margin for catastrophe is not that high in some of these patients. And so it's really important to have good technique, which we'll discuss. Here's a patient with a chronic total occlusion, tried to cross from above, couldn't, tried to cross from below, was not able to. And so for this patient, I put a snare from below, and just using a 22 gauge chiba needle, I was able to direct it into the snare and then treat however you'd like to treat. So what's wrong with needles alone? Okay, whether it's jugular needles, transjugular TIPS needles, or chiba needles or transeptal needles. Well, they really have very little directionality. Even a TIPS needle you can torque, but it doesn't have as fine a sort of a correction as something else, and that's the Baylis power wire. And this has really changed our practice over the past 10 years that we've been using it. This has allowed us to convert patients that we have failed at to patients that we've succeeded at. And that's a big difference, all right, between nothing I can do versus I treated you and we're good. And the RF wire is basically a radiofrequency energized wire that will burn through almost anything. It doesn't burn through cement, doesn't cement like occlusions, it doesn't burn through bone, it doesn't burn through metal, which is good because we can actually use it. When we hit a snare from below or above, it actually shuts off, which is a nice sign. And this technique, just as a shout out to one of my co-panelists, was really taught to most of us by Dr. Guimaraes over 10 years ago now. And this has changed our practice. So let's show some examples. This is a patient with a central venous occlusion. You can see rounded from above, rounded from below. There's no way you're crossing this with a glide catheter or a glide wire. Tried with a 22 gauge chiba needle and actually was not able to get in. It was hard to redirect. And so this is where the RF wire really is important. And so I can meticulously triangulate, which we'll discuss in a moment, and get the snare from below and the snare from above to meet the RF wire and actually get this patient access. So what do I mean by meticulous triangulation technique? Well, I think this is really important whenever you do sharp recanalization, and certainly when you do RF wire recanalization. And what that means is every millimeter I move the wire, the RF wire, I'm looking at AP and bilateral oblique for every single throw. And I want to make sure that my RF wire and my snare are perfectly aligned in every single projection. And that will be the difference between failure, even by 1 or 2 millimeters, and success, where you can capture the wire, externalize it for through and through floss access. Here's a patient with a central occlusion. I think this is really where CT matters. You can see there's one stump here, but my wire is trying to recanalate a brachiocephalic vein. And so why wouldn't I go through this stump? Isn't this part of it? Well, no, that's actually the right atrial appendage, whereas that is the central venous occlusion in the blue arrow. And so again, if you burn through the right atrial appendage, that's clearly potentially catastrophic. And so meticulous triangulation technique and really good attention to three-dimensional CT multiplanary formats and correlate those to your angiographic images, I think are really essential for success in this procedure. You also have to understand goals and risks, okay? So every time I recanalize with sharp recanalization or RF wire, I'm usually, almost always, looking to stent. Angioplasty alone has pretty low patency rates if you go extra anatomic. Now, that said, there are times where I can't stent. Here's a patient with cardiac leads, and you really don't want to jail cardiac leads with a stent. That's really contraindicated. And so you have to ask yourself, is RF wire or sharp recanalization in general appropriate for this patient if I can't place a stent? Can I try something else? A drug-coated balloon, for example. And so goals and risks, what would I do if I did have to stent either emergently? You got to be cognizant of. Last thing I'll remind you is that there are monsters around every corner. Be careful where you're burning through. A lot of these are extra anatomic. Sometimes you can stay true lumen, sometimes you can't. Certainly you've got high price real estate in the chest. You have high price real estate in the iliac veins. You've got high price real estate coming from the left brachiocephalic vein. There's a lot of dangers around. So really study your CT, make sure what's surrounding before you make your passes, and certainly before you angioplasty. I'll remind you that you have to be prepared for emergencies. Here's a patient with a central venous occlusion. This was an RF recanalization, and I did a very gentle balloon angioplasty. Everything looked good, except there was a rupture, and this is a pericardiogram. And I'll remind you, the pericardial flexion extends high above, probably higher than most people think. This patient was becoming unstable, and so this patient got a stent graft, and these are always in my room, always readily available. No one has to look for it. And so this patient did well, and their life was saved because we were prepared, and actually their occlusion was treated. So that'll be it for today. I'm going to say I'll draw your attention, a little bit of a plug for this article that Dr. Holly and I wrote on evaluation and management of chronic thoracic venous obstruction. It goes over sort of a lot of what we talked about today and then a little bit more. So in summary, TCVO is often encountered in patients with end-stage renal disease and cardiac leads. The interventionalist has to have disease-specific expertise, know how to evaluate it, how to treat it, and all treatment options. Almost all central venous occlusions can be crossed with conventional or advanced techniques, but technique matters, okay? Technique matters to ensure an optimal efficacy and safety. And that's it. I really appreciate everyone's attention. Thank you very much.
Okay. Mark, I apologize. It's North Carolina. So
I mixed them up too.
Sorry?
I mixed them up too. That's all right.
Yeah. So Mark's from North Carolina. My mistake. Just we're waiting for questions to come through. But in the meantime, Mark, what about ECG leads? I saw on multiple examples that you had patients with ECG leads in. Are there any special steps you take with those patients? And yeah, Marcelo's also in on the call, so I throw it out to both of you. What do you do when these are present?
Yeah, it's a great question. So, so two things. One, when you've got defibrillator leads or pacemaker leads, you can certainly turn the pacemaker off if the patient's not dependent on it. You just put a magnet over the chest. We've done it both with and without that. Certainly if you're going to be in contact with the leads, I'm more comfortable shutting them off as long as the patient can tolerate it. These are done under general anesthesia by that time. And so we have cardiac anesthesia available. And then the other thing is, no matter what I do, whether I'm using the power wire or sharp, if I'm angioplasting a cardiac lead, my practice has been to actually have the lead interrogated, have the cardiac device interrogated post-procedure, which is really easy to do. You just call the rep, they come over, they interrogate it, make sure everything's okay. And that's sort of an element of safety I like, regardless of how I've crossed, if I have any intervention around the lead.
Okay. Marcelo, anything to add to that?
Yeah, I think I pretty much do the same thing as the Mark does. We always try to understand what type of lead, what type of pacemaker the patient has. The most modern pacemakers can be temporarily turned off, and you just need to use a magnet on the patient's chest. And typically, we recommend to do these procedures under general anesthesia with an anesthesiologist that feels comfortable. taking care of that. Also, a team, anesthesiology team that knows how to place a pacemaker, temporary percutaneous, transcutaneous pacemaker in case there's a damage of the lead. So I think those are a few key elements that we always take into account in order to perform this type of procedures that are relatively risky and increase the safety profile.
Okay. We do have a question from the audience, and this is to you, Mark, but how do you choose between different weighted tips and shapes?
In terms of the crossing wires?
Yes. So do you use like a 3 gram, 10 gram?
Yeah.
How do you determine that, and how do you determine a predetermined shape?
Yeah, it's a good question. So for Venous, when I use a weighted, I always go to 30 gram. I don't mess around with the 014 20 gram tips. And there's some 12 gram tips. If I'm breaking out a CTO wire, it's because it's really my last thing before I'm going to escalate to a sharp or a Baylis RF wire. And so I just go right for the 30 gram tip. In terms of pre-shaped wires, the only thing I really use, to be honest, is just a angled stiff glide wire. I haven't found angled wires different than that to be a benefit. I'll use the catheter more to find the microchannel rather than use a shaped wire. And to be honest, just to make sure, most of this work is with 035 systems. The only time I'll try an 018 system or an 018 weighted wire is that intermediate step where I think I have a chance of crossing without sort of going to the next level.
Okay. I think possibly we'll circle back to it. We should get on to Marcelo's talk for time, but the Baylis power wire does come in different angles as well. So we'll
so if you're talking about, and I figure Marcelo will cover the 75 versus the 110, when to decide that. And we can certainly leave that after Marcelo's talk.
Okay, let's move on to or move on to Marcelo's talk here, please.
Good evening, everyone. My name is Marcelo Guimaraes, and it's a privilege for me to be here tonight to discuss about the sniper technique in central venous occlusions. We'll have the opportunity to discuss a few details. It's a privilege for me to be joining here colleagues that I have a lot of respect for, and being in a wonderful venue promoted by Baylis Medical in order to discuss central venous occlusions and from different perspectives with people that have a lot of experience, and I'm grateful for being here. So these are my disclosures. So first of all, whenever we perform central venous occlusion, it's important to have a plan ahead of time and anticipate complications. All these cases we perform under general anesthesia, which is an evolution since we started performing under moderate sedation only. Basically, if there's something going wrong, we want to make sure general anesthesia folks, our colleagues, are taking care of the patient. We only perform this procedure in the hospital where CT surgery, cardiology are immediately available in case we need to have some surgical repair or immediate surgical intervention. We don't do this procedure in a building where we don't have that support. We cover several places across the MUSC campus. So it's important to us to have the backup. It's important also to have an action plan in case you cannot fix that complication. So that's why I think cardiology and CT surgery are critical. We always order type and cross as a backup in order to make sure if the patient bleeds, we are ready for transfusion, and we also have blood reserved in every single case, just in case. So in every single procedure that, especially central venous occlusions involving the superior vena cava, we always prep the subxiphoid window to get access to the heart. We like to mark, prep, drape, leave everything ready. We have a curvilinear ultrasound always turned on. The ultrasound machine is always turned on. And the pericardium tray is always available, handy. And the team knows exactly what to do in case we have any complication related to our procedure. So subxiphoid window is marked, prepped, and draped, pericardium tray, and the chest, and also we have a chest drain handy in case there's any hemothorax or pneumothorax. And all these procedures are done under general anesthesia, as I mentioned. So initially, we like to have a simultaneous central venogram, ipsilateral to the occlusion typically. So if the brachiocephalic veins are occluded on the right, or then we stick the right arm and then also the groin. The goal is to have either right or left side of the groin, doesn't matter. But what is important is to make sure that we can inject from both sides in order to have a real good understanding about the collaterals, about the length of the occlusion and the diameter of the stems. And as you can see in this central image here, for example, you can't really see where to start connecting what to what. So sometimes can be very straightforward, as you can see on the far left of the screen. SVC occlusion, super straightforward, what needs to be connected to what, but sometimes it's not that straightforward. So central venogram from both sides is important. We are actually more doing that nowadays is to do a cone beam CT with the catheter injecting from above and from below, doing this central venogram, simultaneous central venogram under cone beam CT, and then we have a 3D reconstruction of that occlusion that definitely have helped us to define better, excuse me, the central venous occlusion with the surrounding tissues and the correlation between the occlusion and the surrounding tissues, and where we need to be careful not to cross structures that we don't want to cross. Again, if you don't do a cone beam CT, what you should do is always do an AP view and then 30 degrees RAO and LAO at least in order to have a good understanding. We also have been using more and more long introducer sheaths in order to give us support, in order to give support to have the more precision with the technique, with the tools that we're going to use to cross any central venous occlusion. Another important aspect is it doesn't matter if you come from the arm or from the patient's groin, but if you come from the groin, it's even more important to have the support, as you can see here, with a long sheath, like a 90 centimeter sheath, in order to avoid the movement of the heartbeat, and that can be critical, especially depending on the type of tool that you will use to recanalize the occlusion. It's possible to come, if you use the power wire, in this case, is an example of one of the techniques that we can use. You can have a caudal cranial direction, in my opinion, and that has worked for us. We believe that there's a lower risk of cardiac tamponade if you come from below. But the problem is you have more instability, is more unstable because of the heartbeat. So one more reason why you need to have a sheath, as you can see on this picture on the left. But you can also come from a craniocaudal direction that from above, again, in my opinion, I think is a more stable axis. You have a larger target, either the SVC as a target or the right atrium as a target. However, there is in theory high risk of cardiac tamponade. So among the tools available in the market to cross central venous occlusions, total central venous occlusions, we have the colapinto needle, the back end of the stiff glide wire, the Outback device, and the Pioneer device. And the first two ones, I think, can be, we have to be very careful, because as you advance the sharp device, sometimes you can advance too much. So you need to have some control. And if you compare with the technique that we have been using more frequently, which is the sniper technique that we described several years ago with the power wire, then the power wire in my hands, in my opinion, I think has a more precise advancement and more control versus a needle or a back end of a stiff glide wire that you can sometimes, after you cross that fibrotic tissue, you might go too far depending on how much force applied to the tip. So the technology of the power wire, it's basically have a generator that typically we use 1 second of pulse in the pulse mode of energy. And the guide wire is insulated across, and then only at the tip, the both ends, there is the area that are active. Or one side you connect with the cable that is connected to the generator. On the other side, is the active tip that you're going to be pushing against any tissue, soft tissues. It crosses basically any soft tissue. It does not cross calcifications. Here's a drawing, a schematic drawing of the technique in a few words. Basically, you have a 10 millimeter snare, 10 millimeter snare in one side, and on the other side of the occlusion, you have the RF wire. You make sure you are all aligned, and then we can fire the RF wire through the occlusion and using the snare as a target. And then you can do angioplasty, stent placement using the conventional techniques. One important principle that we always advocate to the people who want to use the sniper technique is to try to reduce the length of the occlusion at all possible and make it as short as possible. And sometimes you use the RF wire as to get out of the vein. You cross without activation, and then use the RF wire to get back active again, to get back into the vessel. Other scenarios, you don't have that option. You need to cross with active RF wire for the entire time. Of course, a little bit more riskier, but at the same time, if you are aligned, if you are precise where you need to be in that track, then you should have no problem to keep it activated for the entire time while you are advancing it. So here an example that we should always make sure that the semi-curved catheter that has the curved power wire or the straight power wire is always aligned well in multiple views with a snare in order to make sure that you have precision. This is a classic example that I like to show because at this point, after doing this one picture, and I always say to our fellows, one picture is no picture. We need to take multiple views to understand that the correlation of the anatomy, right? So here at this point, after one picture, he said, "Oh, looks good. I think we are ready to use the RF wire." That's what our fellow said. And in reality, taking another picture, we realized that we were totally off. We were in total different planes, as you can see in this third picture on the right side of the screen. We are actually in the azygos vein and not in the brachiocephalic junction. So we immediately detected that, as you can see here. So we pulled back the catheter. Now, yes, we are in a perfect spot. You can see in 3 views, we're very much aligned. And then we're able to use the RF wire very safely. This type of alignment, as you can see, with the RF wire almost going tangential to the snare is not acceptable. This is a pretty good alignment, and this is an excellent alignment. But the 3 views, AP, 30 degrees RAO, 30 degrees RAO, have to be aligned. Sometimes you need to push the catheter. It can be a Compi catheter or a Cobra catheter. You need to push a little bit in order to fold it up a little bit, and then you have a better angulation, especially in brachiocephalic occlusions, as you can see, and it can be very tortuous track. So it doesn't matter. As long as the track is stable, the catheter is stable, you can do some maneuvers with your diagnostic catheter in order to make sure the RF wire is aligned with the snare. Once we snare out, we like to do the body floss technique. You snare out the Baylis power wire. Then we exchange that using a 125 vertebral catheter, for example. We cross from the patient's arm or from the patient's towards the patient's leg or from the leg towards the patient's arm. And then our wire is removed. And then we exchange that for a 0 to 35 amplets wire, 260, and then we're ready to work. Typically, we predilate the track with a 4 millimeter balloon after we make sure that we are not crossing anything that we don't need to. And very frequently at this moment, just before we do the predilation balloon angioplasty, we like to do another spin to make sure that we didn't cross anything that we don't want to. And then you can stent and have a good outcome. One thing that we have done over the years is to use the body floss in a single wire technique. And in one side, that's an evolution of our technique again. We learned that, especially in SVC, you don't want to have time. You don't have time to go to the preparatory to the stock room, to the supplies room, and say, "Oh, let's see what type of stent we want to have. Let's measure the stent. Have time to bring it back and open up." No, everything should be open, ready to be used. For example, in one side of the 0.35 amplets wire, we have a 4 millimeter balloon. You can see the markers on the left side of the screen. And then on the same wire, we have already the cover stent, in this case, ready to be deployed. So we basically do an angioplasty balloon for predilation with the 4 millimeters. And then in a fraction of a second, with the screen marked already or doing some fusion of image or road mapping, we already have exactly the beginning of the end of the stent, and then deploy the stent immediately. So in case we create any tear in the pericardium sac with a predilation, we immediately cover that with a cover stent. And that's just a picture showing a cover stent coming from the left side and the angioplasty balloon coming from the other side. It doesn't really matter which one you go. Typically for shorter balloons, we come from the arm, and for the longer shaft devices, we come from the patient's groin. It doesn't matter really, as long as we have length to have both at the same time. And you can see here in the yellow dots is exactly what we do. We mark the screen of the angio suite, and then we define exactly what we need to perform angioplasty and stent placement. Typically, we don't use bigger than 10 millimeter stents. I don't think that being bigger is good. I think we need to understand that the veins are going to be dilated because of the occlusion. And once you open up with the 10 millimeters, and we never had an issue with that, 10 millimeters in our experience is enough to open up. We never went to 12, 14, 16 millimeters, and that's enough to have good flow in case the patient is a dialysis patient, or to relieve symptoms in case the patient is symptomatic. Another important thing to share we learned along the way is that if the patient has bilateral brachycephalic occlusion, you don't need to open up both sides. Open up one side, and typically my favorite one is on the right side, because you avoid crossing in front of the supraortic vessels that can be quite challenging sometimes, crossing recanalizing the left brachycephalic vein. In the subclavian vein, you typically place self-expandable stents. In the SVC and in the brachycephalic veins, we place cover stents, balloon expandable, in order to have precision on the deployment of the stents. Always important to avoid to jail out the brachycephalic subclavian transition with cover stents, so watch out for that. And here's an example. We have a bare metal stent, not cover stent, a bare metal stent. I did on purpose because I didn't want to jail out anything. Precision, very precise deployment. You can see a little bit of contrast there on the far right picture, showing a little bit of contrast bouncing back to the brachycephalic on the right. So on the left was totally open, and a precise deployment without covering the IJ on the right. Very good, and result with precision deployment of the covers of the stent. One thing we have done, as I mentioned before, a lot lately is to use a cone beam CT in the preparation at the beginning with the simultaneous injection, like you can see on the left side of this image. We also have been using just before we plastic, so right after we cross with the power wire, and then at the end of the case, sometimes in order to document if there's any complications. It's great to use fusion of image. I think we're using more and more technology. Important, the CT of the chest with contrast that was performed in clinic, and then fuse that with the angiography. We can also do a rotational angiography, a cone beam CT on the table with contrast, and then fuse that, which is what you can see on the right lower quadrant. The orange image is exactly the fusion of the rotational angiography done on the table and fused. This is called integrated registration, fused with the image of the cone beam CT taken on the table. So fusion of the diagnostic with the angio suite imaging, or the cone beam CT fused with the diagnostic. So you can do both. This is a classic example when we need to have very precision. Enormous ascus, should always avoid to cross the ascus. Ascus is an important collateral. We don't want to cover that. And you can see here the stent is flushed with the ascus and with a very good outcome, as you can see here. As you can see now, we are typically working a BNAST and the SVC. It's typically a very small space, about 10, 12 millimeters between the aorta, pulmonary artery, and the lungs. And I'll stop here in order to see if there's any questions. Again, it's my privilege to be part of this session. Thank you.
Okay, are we back live? Okay, there are a couple of questions that did pop up related to a previous question. We do have two questions from the audience. There was a specific question about the RF wire in terms of the different gram-weighted tips and shapes. And how do we select the different gram weights and the different tip shapes in doing these occlusions?
So I can address that. We talked about sort of non-power wire gram tips, but so I don't use the 50. Let's get that off the bat. I don't think I've ever used the 50. So the only ones I have in my practice are the 75 and 110. And to be honest, I'm much more interested in angle than I am. So generally I'll triangulate, cone beam, whatever it is you do, and sort of determine what is the best angle. I will tell you the tip I've learned is I am much more likely to use a straight power wire with an angled catheter rather than the angled power wire. So I tend to rely on the 75 straight most of it. In terms of switching between the 75 and 110 for weight alone, I'm happy to hear what you all think, but I've never been in a case that I can remember where one didn't go and then I switched and the other one did. It's more often that one didn't go because it was missing and I need an angle and switch to a different angle. But so I'm a lot more cognizant about the angle than I am the weight.
Marcelo, anything to add to that?
Yeah, I think it's important to review, and I agree with Mark. Let's just review real quick the tip shapes that the power wire is available. The tip can be straight, can be an angle 20 degrees, can be angled 30 degrees, and angled 40 degrees. And in terms of strength, straight tip is available in 50 grams, and 75 grams, and 110 grams. And the angled tips, the 20, 30, 40, are available at 110 grams. And as you can imagine, the higher the grams, the higher the weight, the stiffer is going to be the guide wire. So there's a direct correlation. Higher the gram, higher the weight of the tip, that stiffer is going to be the guide wire. In my practice, what has worked for us over the years is to use and I agree with Mark 100%. I prefer to start any case with a semi-curved catheter. For the vast majority, we use a Compi catheter, semi-curved. Rarely coming from the right side, I need to use a Cobra to have a better angle, or sometimes if you have a flush occlusion at the level of the confluence of the right and left brachycephalic veins, and there's a flat line between the two veins, sometimes a Cobra from the left, and it works as well. But the majority of the cases, semi-curved Compi catheter associated with a straight RF wire, and typically I use a 75 grams weight at the tip. That's my goal combination for majority of the cases. However, over the years, we had challenging situations, especially using a semi-curve, recanalizing the left brachycephalic vein, that you must use a semi-curved RF wire, power wire. And the reason is your semi-curved catheter won't be able to get out of the vessel where it started, to give you direction. And in that situation, the direction will be given just by the power wire. And in that scenario, a semi-curved catheter or a curved catheter, in my hands, we typically use, it works for us, a 30 degrees angle is the one that I would use in order to give me direction. Especially important in the left brachycephalic vein, where typically is not a straight shot, is a semi-curved shot. It's a curved anteriorly between the sternum and the supraortic vessels, and you have to be very careful as you cross.
Okay. Now, we were talking about targeting as well, and you're talking about 3 views, Marcelo. Has your practice changed more towards using cone beam CT instead of the 3 fluoroscopic views?
I think, yes, it has. The short answer, yes. We are doing, I would say, 100% of the cases today in the equipment where we have cone beam CT available, and we plan cone beam CT ahead of time in every single case. And the reason is, I think the 3 views is a very important thing, and that's what I have used over the years for the last, I would say, the first 8-9 years of our experience. We used 3 views only, and that it worked for us. But going back in time, I realized that I think we have more information with the cone beam CT, because you were injected from above, injected from below, from both stumps, and you can see perfectly well the correlation with the, let's say you are recanalizing the brachycephalic. You see the supraortic vessels, you see the lung, you see the pulmonary artery, you see where the right atrium is, you see where your snare is, you see if you are posterior, anterior, because in reality, you only have two views, right? For the most part, even if you do obliques. And I think the cone beam CT giving you a 3D dimension, in my practice, has added.
I'm sorry, we lost you, Marcelo.
Can you hear me?
Yeah, we just lost you for 12 seconds.
What I said is, yes, we definitely moved to the cone beam CT in the last 2-3 years. And in the past, we were doing the AP, RAO, LAO, but now we would just do cone beam CT because adds value. We see more details around the segment that needs to be recanalized, especially in central venous occlusions, when you want to see where the pulmonary artery is, where the right atrium is, where the stumps are, where the lungs are, and plan the crossing more carefully. Not only do we use cone beam CT during the initial diagnostic angiogram, venogram, but also during the post-crossing. We want to make sure that after we cross the RF wire, pre-dilation, we want to make sure the RF wire has been crossed to the right place, right where we want it to. And then at the end of the case, sometimes we do a final else as well. If I'm concerned about any complications, we do a cone beam CT as well.
Okay.
And I think that all adds value and safety.
Okay, in the interest of time, I think we should move on with my talk. Although Marcelo did cover a majority of my points in his talk. So repetition is probably a good thing. We'll get through that, and then we'll come back to some more questions after that. If we could have the fun.
Okay, let's keep going. Well, thank you, Marcelo, for that talk. I'm following up with the evening and providing the last talk. We'll have a question and answer period after this talk, but I'm going to talk about managing complications, preventing reocclusion, and then maintaining patency after getting through that central venous occlusion. I think when you talk about complications, one of the big steps is recognizing that you actually had one. You should be aware that with these central venous occlusions, you could get hematomas in the mediastinum, up in the neck. You could get venous dissections, arterial dissections. You could get extravasation into the pericardium, into the mediastinum. You could have an inadvertent arterial puncture. And again, as mentioned, hemopericardium, hemothorax, and even chylothorax are potential complications. So it's important to recognize that these can happen, and they do actually happen. When we look at published studies that have occurred recently, I actually focused on the more recent studies, and there's been a number of studies published actually in CVIR. And if we take a look, regardless of the device, if you're using a Shiba needle, if you're using a transeptal needle, an 18-gauge needle, stiff end of glide wire, or using mother-daughter technique or mother-child technique, as they call it. These studies all had complications: pericardial effusion in one, hemothorax in another with hemopericardium, 2 hemopericardiums, 1 hemothorax, 2 hemopericardiums, 1 hemothorax. So you're seeing a pattern here, and these are not with the RF power wire. Majority of the bailouts were stent grafts. When we look at the RF wire outcomes, these are the few published studies. Marcelo has the largest published study and great technical outcomes. The HEA1 pericardial tamponade resolved. And in this one study, they had 1 SVC perforation in the pericardial space, similar outcome, and 1 tracheal perforation in the smaller study in JVA. The first step to avoid complications is to be ready for them, I think, but actually proper planning before undertaking these interventions makes a big difference. So I personally like to have CT venography if I can obtain it before doing these interventions, so I can understand what the venous anatomy looks like, what area I have to traverse, what potential orientation I have to advance the needle across. So if I have biplane available, this helps to visualize in 2 planes while you're doing the intervention. And occasionally, if you have CT cone or cone beam CT available, just doing a rotational scan and see where you are before you advance to where you want to go might make a big difference in the outcomes. Having access from both directions, I like to have access from above and below. This allows or facilitates basically through and through access. But I like to personally work when I'm dealing with these occlusions from the femoral axis upwards. I like to work away from the heart rather than towards the heart. I think personally this reduces the risk of complications. And once I do get through and I have through and through wire access, let's say I've snared it And now I've got upper access, lower access, but one single wire. This allows me to pass bigger balloons, potentially stent grafts, or anything that might help with dealing with complications. Once I get that through into wire access, I cross the occlusion with a small catheter and I inject contrast along the track. And if it looks good, then I sequentially dilate with small balloons going up to big balloons and injecting contrast each time to make sure that everything looks good and that I don't have a potential complication. The next step is actually recognizing and accepting that you did have a complication. The biggest one I do worry about is pericardial tamponade, so hemopericardium. It's important to recognize these clinical symptoms: dysphoria, confusion, tachycardia, hypotension, distal heart sounds, elevated jugular venous pressure, pulsus paradoxus. But if you have any concern whatsoever, one of the simplest things you could do is take the ultrasound machine you have, look subxiphoid up to the heart, and see if there's any fluid around the heart, and see if that fluid is growing. Because if that's the case, then you've made a diagnosis, and you could treat right at the same time. So in terms of bailout equipment, I like to have large balloons for potential tamponade, large sheaths to deliver these large balloons, ultrasound with drainage catheters. If they have a pericardial effusion, you can stick a drainage catheter in immediately. Support team. When I first started doing these cases, I like to let the thoracic surgeons know I was doing them, so that if something happened, they were aware of it and they could pivot very quickly. And I also wouldn't recommend starting these cases if you're early in your experience at an outpatient clinic. It's a good thing to have surgical backup if you need it. And most importantly, personally for me, is having stent grafts available that are an appropriate size as well. One of the real bailout things that people don't mention is if they are a dialysis patient, they have high flow through that. It's all going to, let's say, into the lungs space or the pericardial space. You could actually include the dialysis access to decrease flow and potentially avoid a life-threatening complication or a life-threatening outcome. I'm just going to highlight a personal case we had where this person was occluded centrally. This was actually pretty easy to reverse. We just took out the catheter, but we balloon dilated this, and the balloon opened up. And when we injected contrast, there was staining in the mediastinum, but we also saw contrast staining within the pericardial space. So a real concern. The patient started acting a bit wiggy, let's say, and quickly dropped in a 10 millimeter fluency stent graft in this case to deal with that lesion. And again, with this run, you can see no extravasation. I'd like to point out anatomically, this is a good MR image that shows that the pericardial recess actually comes up very high. In this case, this is the superior aortic recess of the pericardium, but on the lateral side, it could actually extend up along the SPC to the base of the neck and around the jugular vein. So when you are traversing these areas of occlusion, it is possible to end up in the pericardial space, and understanding that these recesses actually extend pretty high up makes you understand how these complications can happen. Let's say you are now successful, you've gotten through, you haven't had that complication, but you really want to maintain patency. So once I get through and I've done what I like to do, I just monitor clinically. I don't actually monitor them angiographically. When you do an angiogram, you're tempted to treat, but really you should only be treating off clinical symptomatology. So I only image when they develop a clinical symptom. And in almost all cases, I'm doing a diagnostic fissiogram because I could treat potentially at the same time. Rarely, ultrasound can tip you off. You could see some dilated veins in the neck. With ultrasound, you can see collaterals, or you could see a bit of a flow dampening with the axillary and subclavian veins. I'd like to point out, actually, in this meta-analysis we have coming up, me and a couple of co-authors, where we looked at angioplasty and bare metal stents for central venous stenosis and occlusions. But remarkably, the primary patency rates at 12 months are under 40% for both. They're very similar. So bare metal stents actually don't confer any long-term benefit compared to angioplasty. Part of the reason why I prefer stent grafts. So I'm going to go through one of the reasons or multiple reasons why I use them. I prefer them over stents. One is the thought of better patency. I'll get to that. But the devices have become better over time. You now have 14 and 16 millimeter devices that are available, and the iliac looms from EVARs are also an option for bailout. They prevent tissue ingrowth, so stenosis over time is reduced. It excludes holes through things. Let's say you have a tracheal perforation, that'll exclude it. Let's say you have a hole to the pericardium, I'll exclude it. And once again, bare-metal stents and PT have a similar outcome, whereas stent grafts have a bit of a better outcome. I'll show that to you shortly. And let's say at a later time, these are very complex patients. Let's say the stent graft does occlude. It provides a target for you to potentially puncture into and a pathway to get through to recanalize and potentially reline to get access back. And so just an advanced intervention, but a benefit of stent grafts that's potentially long-term. In terms of stent graft outcomes, there are very limited studies to date. One in 2011, another in 2016, 2021. The numbers are limited, but in two studies using one called the Rhapsody device that's coming to market soon. The Vibon is very common and well known to people. You could have primary lesion patency of 100% in these two studies, these two latest studies, at 12 months compared to less than 40% with bare-metal stents and angioplasty. The Jones paper is still 67%, not bad, but kind of interesting to see how over time the patency did get better. Just, I want to point out in KDOQI guidelines published in 2019, it is reasonable to consider placement of a stent graft as long as you consider future AV access options. In other words, don't put in that stent graft if you lose the potential for better access down the road. But more importantly, it is reasonable to avoid use of bare-metal stents for clinically or angiographically significant AVG and AVF stenotic lesions. So stay away from bare-metal stents. I've been asked, what about drug-eluting balloons for mating patency of central venous occlusions? This paper specifically looked at central venous stenosis, not occlusions, but a well-done randomized prospective study. And they looked at the intervention-free survival period for CVS. And the median intervention-free survival was 180 days versus 124. It was better than angioplasty, and this was a randomized prospective study. But again, a bit low, so I still tend towards stent grafts. In conclusion, it's important to recognize when you've had a complication and actually mentally accept that you've had that complication. Once you've accepted that it's happened, you're going to take the right steps to deal with it. So be ready for them. Have certain tools available. A lot of you do on the shelves. They will come in handy. If you've worked hard to get through that occlusion, I prefer a stent graft because I think it provides the most durable solution in terms of maintaining patency, but also dealing with potential complications. You know why? And that is the end of my talk. Thank you very much.
Dheeraj, you're muted.
We're near the end. We have a couple of minutes left. There was a question that popped up from the audience. Do any of you use steerable sheaths or steerable catheters to support the wire? The power wire. Let's say like an Oscar sheath.
Yeah. I can answer that. So steerable catheters, yes. Steerable sheaths, no. I don't generally use those. I'll use angled guide catheters, like an MPA inside a sheath, but nothing that's steerable.
Okay.
Yeah, I agree with Mark, Dheeraj. I only use either a straight sheath if I come from the groin to support, or I come from the arm. I typically use a semi-curved introducer sheath to give support. I don't use guiding catheters, and I don't use deflectable sheaths.
Okay, for all these cases we've shown, we've always used a snare as a target. In all your cases, do you always use snares as targets?
Who's that directed at? Either of us?
The panel.
Okay.
Mark and Marcelo.
So yeah, I don't want to. So no, you have options. So what we've done before, we've targeted balloons. We've targeted, again, you've got to be cautious, cardiac leads. It's been described, I haven't done it, but it's been described targeting stents, opening a stent for the sole purpose of getting through it. We've targeted stents that are already in situ, but using it as sort of a de novo target. So no, there's a lot of different options. I tend not to just target a contrast column. That's the main point. I want something on the other side almost always.
Sorry, Dheeraj, can you say that again? What was the question? If we use a target?
The question was, do you only use snares as your target, or do you sometimes not use snares or something else, or maybe nothing at all?
If I'm going to use a conventional technique like Mark described with a glide wire, for example, I don't use a target on the other side necessarily, especially if I have a good diagnostic CT done up front. Sometimes you can fuse the diagnostic CT on the table so you have an idea what is on the other side. But if I'm going to use a sharp recanalization with the power wire using the sniper technique, then I definitely use 100% of the time, I use a small snare. I think smaller snare is better than a bigger one because you have a more precise target. There was one picture on my talk of having a pigtail as a reference. And that's what we did for the first time. Quickly that we needed to snare out to do the body floss technique. So we decided to use a snare as a target instead of a pigtail, and then change the pigtail for the snare. So yes, long story short, 10 millimeter snare in 100% of the cases.
Okay, we're running over time. I think there's time for just one final question from the audience. The question is, do you have cases of edge stenosis with central venous stent grafts? And if so, how do you deal with them? And do you deal with them as you do with peripheral arteries?
Yeah, so I think that the conversation of stent is interesting because the three of us, I think, disagree a little bit in terms of stent sizing and in terms of what stents to use. I think that's an interesting point of controversy. I do agree with Dheeraj that obviously there's some good data for stent grafts. My concern about stent grafts is some of the literature demonstrates a very high rate of jailing of other veins, and so clearly, if you're meticulous and you're very good experience, I think it's very safe, but I would caution you not to jail other accesses. That said, there are options of salvaging that. You can stick through a stent graft to get a dialysis or a hero graft in, but that's another point. In terms of edge stenosis, I treat it just like I would anything else. If it's asymptomatic, I'll leave it alone. If it's symptomatic, I'll treat it with angioplasty, potentially DCB, and potentially stent extension if the anatomy allows.
Agreed.
Well, one comment I'd like to make there is the occlusion of central venous stents is that we have used the RF wire to recanalize occlusion of stents that are chronic occlusions. You just have to be careful, of course, not to go tangential through the stent struts with the RF wire, number one. And so in order to get access, sometimes we like to use we like to match the size of the vein where the stump towards the stent is. Let's say it's an 8 millimeter subclavian vein. We like to inflate a balloon inside the vein to centralize the wire, and they use the RF wire to poke in the center of the stent. So you are in the center of the stent. And as Mark said in his talk, if you touch the metal of the stent with the RF power wire, it's going to shut off because it will be an sudden increase in impedance shift, and that shuts down the system. So then we just go in small increments with intention to cross. We have done several cases over the years that we will never be able to recanalize any of the stents without the sniper technique or with the power wire technique.
Yeah.
Okay. We are 4 minutes over time. Jody, I think we should wrap this up. I want to firstly thank the audience for attending tonight. It's always hard to find time in the evening. Then a very special thanks to my panelists, Mark and Marcelo. We drew straws, and unfortunately, I got the short one. These guys are fantastic and really have made the program tonight. So I thank you both for this. I thank Baylis for providing the opportunity to people tonight, but most importantly, I thank the audience again. With that, I think we'll end it.
Thanks so much.